Welcome, everyone. My name is Sophia DeGiorgio, and I work in marketing and communications, outreach, and engagement at the University of Iowa Healthcare. Thank you for joining us this evening for our Meet the Midwives webinar. You'll hear from our experts on our nurse midwife team shortly. Before we begin the program, I have a few logistics to share to make for a great virtual experience. This program is hosted in a webinar format, meaning you will only be able to see our UI Healthcare speakers on your screen. In the upper right-hand corner of your screen, you have a few options to change your view of the speaker and presentation. At the bottom of your screen, you can click the Q&A button to submit a question for our speakers at any time during the program. When entering your question, you can choose to submit your question anonymously. We will also be addressing questions that were pre-submitted upon your registration throughout the program. Closed captioning is enabled, and you can choose to turn that on by using the closed captions or CC button at the bottom of your screen. You can adjust the size and placement of the closed captions on your screen with this button as well. Without further ado, we will begin tonight's program, and I will now turn it over to our nurse midwife team.
Thank you so much for that kind introduction. Welcome everybody for tonight's webinar. My name is Amber Goodrich. I'm a certified nurse midwife with the University of Iowa, and we're happy to have you all here tonight to talk a little bit more about what midwifery care is at Iowa, and also to give folks an opportunity to ask us questions. We did get lots of great pre-submitted questions, and we have a good presentation here tonight to help you get to know a little bit about what midwives do, and also maybe some other tips or tricks if you are pregnant, trying to get pregnant, or maybe some gynecologic care. Do us a favor, and if you have any questions, feel free to put it in the Q&A, and we will either answer it live or answer it live by talking, or type in an answer for you. We really want you to make sure that all questions are answered. So we do have 6 different locations that you can find a midwife at. Of course, in the Iowa City area, we have midwives are available at our North Dodge Clinic, as well as Iowa River Landing. And with Iowa River Landing, we do have 2 evening clinics available. And then at main campus, the 200 Hawkins Drive, kind of the big house, we have options as well. And then we also have 3 outreach locations. One of them is in Cedar Rapids, that we're there once a week, and then Washington, Iowa, as well as Muscatine, Iowa. We're really proud to serve folks there so that they don't have to drive so far to the Iowa City area for care. We have ultrasound and lab capability at all those locations as well, so it's really convenient for our patients. Our midwives have grown quite a bit, and so it's really tough to meet all of us before you come in for your big day. So often patients will choose to schedule their appointments with just a few midwives to develop that great continuity of care. But we do have a call pool. So who is on call the day that you go into labor is who gets to take care of you for that special day. So this webinar is a nice way for you to at least see our faces before you come in to have your baby with us. So I'm just we'll take the time here to do some brief introductions of all the midwives, and I just put these in alphabetical order by first name. And I'm gonna have each of the midwives just say your name and where you usually practice, and then I just have some questions for each midwife behind their name, so they'll get to answer those. And I said alphabetical order, but usually I'm the first one, but Abby, I messed this up because Abby actually goes before Amber, so I'm sorry about that. But for me, the question I put is to talk about the myth that you can't have a midwife if you have a high-risk pregnancy. And I should start off by saying I usually practice at the North Dodge location. However, I fill in all the locations often. But lots of different things can technically make your pregnancy higher risk, and I really encourage you to perhaps reach out to the midwife team, even by calling to see if you could perhaps still have a midwife for your pregnancy, because we work very collaboratively with physicians that were often able to take care of some higher risk patients. And Also, three of our midwives are working in the high risk OB clinic, and so they're able to still give patients midwifery care within that setting. Abby, do you want to go next? And your question is, what do you want every first time mom to know?
Hi, I'm Abby. I normally am at North Dodge, but I kind of fill in everywhere, besides Washington. So that's fun. I get to see a lot of different patients for the first time. I'm so sorry, Amber. What was my question?
What do you want every first time mom to know?
Um, I would say it's really important to take time for yourself when you recover because your little person can kind of be all consuming and you can feel like you lose yourself, but it's really important to focus on you and what you need to feel good about yourself postpartum.
Thanks, Abby. And next we have Andrina Timmons. Andrina, what is something you recommend packing in your hospital bag that we don't usually talk about?
Hi, I'm Andrina. Okay, so are we doing like where we work and all those things right now, or just answering
Yeah,
questions? Okay, so I'm Andrina,
yeah.
as she said. I am typically at North Dodge on Thursdays, and then I also go down to the Washington Outreach Clinic, um, and then work at both locations for delivery at the downtown and at the main campus. I think that some of the things that we forget when you go for labor and delivery is just to bring kind of snacks, that things that you like, things that are kind of going to make you feel comfortable in labor and delivery, because we still, as long as for most of your labor and most people's situations, you can still eat during labor. And then I think like music, I had somebody, their husband brought a guitar once and was like in the corner playing music. So that was kind of neat. Different bath. We do have essential oils, and there are different scents that they do have there. There's little lights. There is like a couple little lights that they at one time had, but you can bring whatever you want. Like if you picture yourself at home in a setting that's really comfortable, most of those things you could bring to the hospital with you. But anytime you're just wondering, just reach out and ask us, and then we'll just let you know.
Thanks, Andrina. Um, and then next we have Becky, I think is off right now, but Becky Winnicky is another one of our lovely midwives. Um, and she's kind of entering retirement, and so she's just helping us fill in a lot right now. And then Bree Herring, I think, is unavailable this evening, but she typically practices in the Cedar Rapids Clinic on Wednesdays, and then occasionally she's at the Iowa River Landing Clinic as well. Christina Shutters is a midwife who is on labor and delivery right now, and she's one of our midwives who practices on with the high risk OB team, and then also does birth with the midwives. Next, and then we have Jackie Roman. Jackie, can you tell us what is your favorite part of being a midwife?
It's hard to narrow it down. Oh, P.S. You can find me at North Dodge and the Muscatine Outreach Clinic for the most part. I do fill in here and there, everywhere. There's so many wonderful parts. It's hard to pick a favorite. I mean, who doesn't love being part of the birth experience and having that fun moment and watching your family grow? But I would really say my favorite part is being able to see my patients back year after year for their annual exams and just to watch them grow as moms and people and help them to live the healthiest life they can.
Thanks, Jackie. Next we have Kelly Horn. Kelly, your question is, what services do you provide beyond prenatal care and delivery?
Sorry, I'm trying to unmute myself. So I'm Kelly Horn. I recently relocated back here from Indiana where I practiced as a midwife. So it's nice to be back home. I am clinically stationed right now at the main campus and then North Dodge on Fridays. And I'm going to be delivering at both the university campus and then the downtown campus as well. So that's where you'll find me. I think one of the really cool parts of being a full scope practicing midwife is that not only do we get to walk with women during during their pregnancy and their labor and delivery cares, as well as their postpartum. But we get to see women all throughout the life cycles, from family planning services to normal gynecological cares and, contraceptive counseling. And it's just a joy to be able to be with people for the longevity and the long term and get to know you on a very intimate level and watch your families grow and continue those cares for as long as possible.
Agree, Kelly. Thank you. Next, we have Kimberly Sprague. Kimberly, your question is, how long have you been practicing as a midwife and what types of births have you attended?
Hi. I have been a midwife actually for about 27 years. When I looked at my question that tonight, the first thing that came to mind was beautiful. We attend a lot of beautiful births. But the reality is, having been a midwife for like 27 years, I deliver, of course, in the hospital. People tend to, assume we do a lot of low risk birth, but in reality, we're experts in physiological birth. From the time that I started as a midwife to what we do now, we've made a lot of advances. We've brought in, as midwives, labor tubs for women to labor in. We have birthing balls, peanut balls. We have encouraged women to ambulate and be up and out of bed and active during their labor. So I think in general, we've championed birth and have really supported physiological birth. I typically am at the Muscatine Clinic Thursdays and Fridays, and have been with the university for about 5 years.
Thanks, Kimberly. Next, we have Lastasia Coleman. Lastasia, your question is, how do you collaborate with OBGYNs?
Hi, everyone. Like Amber said, I'm Lastasia. I have clinic at North Dodge primarily, and I am the program director for our midwifery education program. So that's what I spend most of my time doing. How do we collaborate? We collaborate in a lot of different ways. We, we have our practice guidelines that we use, so we know when patients need a consult or referral and things like that. So it's really pretty easy to collaborate most of the time. If we have a quick question for one of our physician colleagues, we can, send them a message. If we need to refer a patient, we can get them referred in. And so the collaboration is pretty seamless, I think, here. In labor and delivery, we have more of a team-based model up there. So, we're all just making sure everybody gets the best care that they can in the hospital. And, we work with our OB residents very much in labor and delivery, helping them with their patients and also catching babies with them or for them if they're preoccupied with other things going on the unit. So lots of collaboration all day, every day up there.
Yeah. I think one of the biggest things is like the midwives don't do surgery. So that's a big way that we collaborate with the physicians too, is they help us with births that need to go to cesarean, which our C-section rate kind of varies month to month from like 11 to 15%. So it's really fairly low compared to the national average, about 30%. But that is another way that we collaborate too. Thank you, Lastasia. Laura Delos, how do you collaborate with doulas? And maybe tell us what a doula is too, for those who don't know.
Sure. I do all my clinic for general OBGYN at Iowa River Landing, are my mainstay. That's my mainstay for my clinic site. How do we collaborate with doulas? It's a great question. And first of all, a doula is a trained labor support person, and that process of training for them can vary, but once they have completed a program and done a test, they can actually say they're a certified doula, and there's several different processes out there for that. We encourage women to choose doulas. The benefits are really well documented, and research has shown shorter labors, lower C-section rate. There's benefits to baby, more positive birth experience for moms. One of my friends who's a doula loved to describe it as Laura takes care of everything. You can't see all the way down to my belly, but everything down and toward my legs. And she takes care of everything back here. So really kind of that teamwork too, of working to support moms and their partners, whoever else they want to have at their birth experience, there through that process. They'll oftentimes meet with people ahead of time. Sometimes they come to appointments with families. And really importantly, even in our most restricted times during COVID, doulas were seen as part of the birth team at the University of Iowa. So my dream someday is that just as our insurance will pay for all sorts of other services related around birth, that every insurance plan will pay for a doula because the benefits are really there. Some health plans will, or will at least pay some contribution. There are also some programs for certain folks that meet the requirements to get doulas covered. And people also use their healthcare spending accounts and flex plans and stuff like that to help cover those costs.
Thanks, Laura. And I also, if I may, Laura, wanted to plug that Laura is a menopause certified provider. And so that's one of the ways that midwives can expand their scope of practice. And Laura works within the menopause clinic at the University of Iowa. So more than just birth, right?
Hey, yeah, you all started getting old on me. I had to go figure out what to do next.
Laura Hannah Bergen. Laura Hannah Bergen works with the midwife team doing births and doing evening clinic, and then also is a psychiatric nurse practitioner. So we're super excited to have her be a part of our team. Laura, how do you assist with breastfeeding, recovery, and emotional well-being after birth?
Yeah, so first of all, I work primarily at the North or at IRL, Iowa River Landing, and I do the evening clinic there on Tuesdays. And I think it's great that we offer these evening clinics because it really gives people that have, busy jobs and like inability to, leave in the middle of the day to come in and get care. So that's really important part of our practice, I think. As far as postpartum, so as soon as the baby is out, we really we honor the golden hour. So the first hour after baby's born, we feel like it's really important to keep the baby skin to skin as long as their recovery is going smoothly, promote breastfeeding by just being with mom. We know that, when we honor that time, that the transition is much smoother for the baby, and also it promotes that the ability for the baby to latch immediately after the baby's born. So that first hour, that's really meant to keep the baby and the mom together. As far as recovery, while you're hospitalized, you may be there for 24 hours, you might be there for 48 hours. During that time, we're in the hospital and available to you as much or as little as you need. We will see you at least once a day in the immediate postpartum, checking in about breastfeeding, your bleeding, how you're feeling, if you're having any pain. And then after you go home, one thing that's unique about the midwives is that we see you both 2 weeks and at 6 weeks. Usually that 2-week appointment, we know how hard it is to get out of the house with a newborn. So we do give you the option of making that a virtual appointment. But the first 2 weeks are pretty brutal. And so it's a really good time to check in, not just about breastfeeding, but also about your mental health and how the immediate recovery is going. Because we know that by 6 weeks, you've already figured everything out, and you may have done it on your own, but it can be really hard if it's your first baby or you don't have a lot of support. So we check in with you around 2 weeks and then 6 weeks, and then as much as you need in between if there's something else going on.
Yeah. Thank you, Laura. Megan Dre, can you talk about the myth that midwives only attend home births?
Hi, I'm Megan. I am one of the midwives that works in the high risk OB department. So if for some reason you risk into the high risk OB world, you'll see me at the main campus along with some of my other colleagues. The downside about that is that we don't deliver your baby. So you would be delivered by our physician friends. You will also then find me on call if you are within the midwife practice, and I will deliver you then. The myth that midwives only deliver in the home, it just kind of depends on the midwife. There are multiple types of midwives depending on background, how they're trained, certificates, testing, those sorts of things that we do to have the credentials that we do. So there are certain types that deliver in the home, and there are also certain types that deliver in the hospital. Certified nurse midwives being mainly delivering in the hospital, and some that have their own practice and deliver in the home.
Yeah. But the midwives all at the university deliver in the hospital. Yeah. Thanks, Megan. Meredith Parizek, talk about the myth that midwives are not medically trained.
Hi guys, I'm Meredith. I am primarily in the Muscatine Clinic on Mondays, and then Tuesdays I'm at the North Dodge Clinic, and then you'll see me delivering at either location. The myth that midwives are not medically trained. This is kind of going off of Megan's comment, I guess. There's different types of midwives, and whether they're delivering in the home or at the hospital, we still all have extensive hands-on and educational training. The fun thing about all of us midwives on the screen here is we were all nurses beforehand. We went to school to become registered nurses and then went back to school for either our master's or our doctorate degree. So like I said, depending on the type of midwife, there's different types of training, but we all have extensive training.
Thanks, Meredith. I think Rosemary might have had to jump off. Yes, right, guys? So Rosemary Anduso is on labor and delivery, and she told me she might have to jump off. So she's a midwife that just joined our practice as well. So you will see her around. Next we have Sarah Jones. Talk about the myth that midwives discourage pain relief or epidurals.
Hi, I'm Sarah Jones. You can find me in the high risk OB clinic. I work there a couple days a week, and then I do deliveries with the CNM division at main campus. I think it's the midwife's job to support you in whatever you choose, whether it be no pain medications like you want a hypnobirth or you want more natural methods of pain relief, or if you want an epidural, that's fine too. Like, we're there to support you in whatever your decision is. And just because you go into it thinking you want an epidural or you don't want an epidural, and you can change your mind. Like, you might get into labor and delivery and you're handling things great and you're just doing great with your doula or your midwife or whoever, your nurse supporting you, and you can do that. I am a midwife who had 3 epidurals, and those were great births for me. And I think that what we want to do is just make sure that you look back on your birth experience positively, and we want to help you achieve your goals.
Thanks, Sarah. Sophia Namazi, this kind of goes off of what Laura Delos was talking about, but can you talk about the myth that midwives are the same as doulas?
Hello, everyone. My name is Sophia. I just joined the university, and my clinic is mainly at Iowa River Landing. So for a myth that midwives are similar to doulas, I tell people about that midwives have a different type of education and doulas have a different type of education. That's really the biggest thing. And the other thing is that the doula is there to support you personally, and the midwife is there for your overall well-being for both you and mom, and make sure everything is going well.
Thank you, Sophia. And that is all of our midwives on here. So we're going to kind of move over to some other topics here. And the first thing I wanted to talk about, Meredith is going to walk us through creating a birth plan, or as the midwives have kind of called, the pregnancy roadmap. And I'm going to try to share my screen. Can you all see the roadmap here?
Abby, I see you're back on here. Do you want to talk about this, or do you want me to take over?
It would be great if you could, if you don't mind.
Yeah, not a problem. Yep, I can see your screen, Amber. So this is our pregnancy and birth roadmap. We start talking about birth planning around between the 32nd, 35th weeks of pregnancy. But here, as you can see on the front page, we're also thinking about your whole pregnancy. And so sometimes people prefer to fill this out at the beginning, where it talks about, things that you want to do during your pregnancy to be as healthy and prepared as possible. I will add, this is on our website. If you search for University of Iowa Birth Roadmap, it pops up there. Also, you guys can create your own roadmap or birth plan as well. Some people will create their own with their doulas, or they'll get on Etsy and have lots of different pictures, or however you want to do it, to be able to share with us your wishes and your desires for your pregnancy and for your deliveries. So going through here, like I said, the top is kind of your pregnancy goals and how you want to be as prepared as possible. I tell people to write all over the paper, fill in the blanks, check the boxes, whatever you desire for your pregnancy and for your birth. This is talking about your birth companions, who you want in your labor room with you, whether it's your partner, your mom, anyone, whoever you want to be there to support you as much as possible to give you the birth that you want. Scrolling down here. So next is the labor tool chest. So this is anything from, the movement and the position changes that you want to be in while you're laboring or while you're birthing. It talks about the option for IV pain medications and epidurals and laboring in the tub, whether you want music going, kind of all those things that are going to make your labor as unique to you as possible. Next, it asks about monitoring during labor. So if you have a low risk, uncomplicated pregnancy and uncomplicated labor, there is the option to get that non-stress test. So you'll come in, and when you come into labor, we put you on the monitor and make sure that your baby's heart rate looks good. As long as everything is low risk and looks good on the monitor, then we can just listen to those heart tones every 15 or 30 minutes. We don't have to be continuously hooked up to that monitor. If you do have any risk factors, or if we're concerned about the way your baby's heart rate is looking, then we do have the option to do the continuous monitoring. But we do have a lot of wireless options. So you can be in the bathtub, you can be moving around the hallways or in your labor room. And so this is kind of a way for you to say whether you have one preference or the other. I think we talk a little bit more about this later, but we do have learners up on labor and delivery. So whether it's medical students, midwife students, or resident physicians, you have the option to say whether you would like someone involved in your care, if you're okay with having everyone in the room with you, or if you want to kind of keep it as quiet and the least amount of people as possible. And so we give you the option to discuss that there. Here's kind of those special requests for the birthing process. And so when your baby comes out, whether you want your baby right on your chest, which again is pretty typical for us, we like to delay the cord clamping. But if you have special requests like, hey, I want my partner to cut the cord, or I want my baby dried off before they're on my chest, anything that you desire there for the actual delivery, you can write that in there. And then, of course, we know that things don't always go 100% like we want them to. So we also want to be able to value your requests if a C-section is needed. And so this is a way to kind of talk about what special requests you have in the event that we need to go to the OR for a C-section. Last page here, some things about the first few hours of birth. So whether you're planning on breastfeeding, bottle feeding, pumping and feeding, whether you're okay with those newborn medications for baby that are all listed there. And then planning for home, whether you want to leave right at the 24-hour mark from the hospital, whether you want to take advantage of the full 48 hours, just those special things that you desire when you're staying on the mother-baby unit.
Thank you, Meredith. Next, Andrina, could you just mention to us what the role of learners in labor and delivery are?
Sorry, can you hear me? I
Yes.
was in the middle of answering one of the chat questions, so I missed what you were saying. Okay,
That's okay.
so go ahead again.
The roles of learners in labor and delivery.
That's like the question I was just kind of answering, but a little bit the staff and midwife question. But so we have students, Meredith kind of just touched on this, talking about the birth plan. And so there's medical students up there, the CNMs, we have CNM students, the staff physician. There's a lot of people on the team, in general. And so like our RNs, are you talking about like during your labor experience? Right. So we primarily we're always in-house with our patients with laboring. We spend a lot of time with them. Like if for example, like primarily like if you need a cervical exam, unless it's like we need a cervical exam right this minute, there's experienced nurses that can do that. But we primarily check our patients, help position our patients, help labor them, all of those things that involve being in the room. And then we always push with our patients. There are maybe couple times where we have to leave and come back, but primarily we do all of that hands-on. And so I think that's something that's really unique to our practice. And so we can spend a lot of time in that. And like medical students, essentially, if the patient is okay with it, they can come in and be towards the end, they can take part in the helping of delivering of the placenta if that's okay with you and your experience, but they can also just be there to observe. CNM students are there and they can do all of that. But once again, it's, they're nurses as well, but it's up to you and your experience. And then we have a staff physician that's like as backup or residents, that if we need them to come in and be with you, a reason that we talk to you first, and they are there if we need to have any sort of, if there's like an emergency situation or your baby, if we just need a consult, like if they need to come in the room, they're there, but they don't really come in your room for part of your care unless we need them, if that makes sense. Sorry, that was kind of a little all over the place.
Yeah, that's okay. I think one of the biggest things is the midwives are faculty in the College of Medicine. And so one of the really unique things about us at the university is we get to help teach future obstetricians. So the residents they're already physicians who are now on their specialty training as OBGYNs, and we get to show them what our normal birth is, and they are really excited and honored to be a part of that experience. Oh, sorry about the little face right there. Sorry guys. I tried to lock myself down in the basement, but she found me. Anyways, and then the midwifery students, of course, are very like near and dear to our hearts because we were all midwifery students once too, and we love being able to teach that. But we also respect that it's your choice if you don't want to have them there, but do know that they are supervised and very happy to be there. Laura Delos, could you kind of go through for us the options for birth, the downtown campus versus the university campus?
Sure. So, for those of you that don't know, the university is now, what was the old Mercy Hospital is now part of the university system, and we refer to that as the medical center downtown, and we refer to the labor and delivery that is across from Kinnick as a medical center university. Not that that's at all confusing, but that's what was decided. So we have great options both places for you. Both units have birthing rooms with tubs. We can intermittently monitor both places. We have telemetry monitoring. All the things are available. Anesthesia is available to us in both places. They don't, just little differences. They may be called in from home at the downtown campus, but at the main campus, they are maybe called from the OR. So there typically is not any dramatic delay in timing of things at the downtown hospital for care. There are 5 LDR rooms at the downtown campus, so it is a little bit quieter unit and has a lovely unit that you go across to after the baby comes for this remainder of the stay. And at the university campus, typically moms move mostly down to the third floor for their postpartum stay after the baby comes. We do have some rooms up on the sixth floor, but most likely people go downstairs. For those postpartum rooms, there is tub access for everyone. It just varies a little bit about whether that is in a room at the university campus. Downtown campus has tubs, I think, in all of their mother baby rooms. We have great staff both places. We don't yet have 24/7 midwifery coverage at the downtown campus. That is a goal we're working toward, is to be able to hopefully cover both places. So if you are interested or planning to deliver at the downtown campus, but know you want a midwife, we might have to redirect you to the university if we don't have a midwife on at the downtown campus that day. That should hopefully be less and less as we grow our practice and are able to cover all of that.
Thank you, Laura. Jackie, can you tell us a little bit about recommendations of things to do to achieve a successful VBAC, general preparation for a VBAC, and maybe even start by saying, how do we support VBACs, I should say.
I feel like we're all very supportive of VBAC. We do do vaginal deliveries after one C-section. Sometimes, depending on history, we might do a VBAC after 2 previous sections, but that's not a super common thing. So, I mean, I don't know what to say aside from we love to see you have a vaginal delivery, and we'll do our best to support you to do that safely. Sometimes it's not safe to do that depending on the previous C-section, but we'll definitely talk to you about your experience and do our best to support you to have that vaginal delivery. How to prepare, bottom line, be the healthiest you can be. We want you to stay active. We know that being active during your pregnancy will help you to have an easier labor. There is recommendations for weight gain in pregnancy. Those are put out by the Institute of Medicine, and we do recommend that you stick to that. We know that if you gain an appropriate amount of weight, you will be more likely to be successful. There are a lot of resources out there, not just for VBAC really, but for pregnancy in general. I think a lot of us recommend or use spinning babies. And while it's helpful to us in labor and delivery, it's actually really important to do those kinds of things during your pregnancy to optimize your muscles and tissues and such to allow your baby to come down into a appropriate position for delivery. So.
Thank you, Jackie. Kelly Horn, the next question is for you, and this is a little bit outside of pregnancy and birth, but how do you go about helping a patient choose a contraceptive method?
I think that's a super good question because it's something that we all come up with a lot, or we come to a lot. I think that I think you have to come in and figure out what the patient is, what's going to fit their lifestyle. So I think open-ended conversations, that shared decision making is the first important part of the whole visit. I think that, you have to understand what their needs are. You have to understand what their concerns are, what their lifestyles are like, and what their health history is like. There's so many different ranges and options of birth control that you have to kind of figure out what's going to fit their lifestyle, but give them all options so that they can make that correct choice. I do think definitely you have to dive into the medical history because there's some that are contraindicated or not appropriate for certain types of people with certain health risk factors, and that is wonderful to educate them on. I think that you have to talk about efficacy or how effective each of the birth controls are for them, how convenient they are so that it's not user error that they're not using it appropriately or at the right time. So I think that convenience and effectiveness are very, very important, and also the side effects that people may experience. So just giving them that big, broad range of education so that they can make those right choices for sure. I think the other important thing is are they really going to try to conceive soon, or is that in the near future? And that may be something that you would alter what you initially were going to suggest for them, and maybe go to something different that would not be such a long-acting contraception, maybe something that would be short-term at that point in time.
Thank you, Kelly.
You're welcome.
Kimberly, when during labor do you want the mother to come to the hospital? Like at what point in labor?
Well, in general, there's an adage that we usually say for first-time moms: when your contractions are 3 to 5 minutes apart for 1 to 2 hours, you come to the hospital. But in reality, as a midwife, we're going to be talking with you, and it's part of our birth plan of, what are your goals? Are your goals to have an unmedicated birth? Are your goals to use an epidural? We take into account your previous delivery history. If you had, really long labors, shorter labors, how far from the hospital are you? And we'd probably, kind of make an individualized plan. The other thing that we do for you at the university is we have phone numbers where we always have you call and talk to a real person. So if you're not certain and you want to talk through it with someone, we have labor and delivery nurses that answer those lines 7/24, and they can kind of help talk you through what's going on. And, if they might recommend, why don't you take a warm bath, et cetera, maybe give it another hour or two and then head this way. Other times, if your contractions are progressing really quickly, you may need to move in to the hospital a little sooner. But ultimately, I always say, trust your instincts and your guts. If you feel like you need to come in and even to be evaluated, come in, call, talk to somebody, come in. Don't be, a lot of people are afraid that if they come in and it's not true labor, that they might get sent home. And it's like, well, sometimes that happens, but that's what we're there for, is to check those things out and, to determine if you are or not in labor. And sometimes it is okay just to go home for a little longer and come back later when things are more active. So it's very individualized, I guess is what I'm saying. And we'll have many conversations about that during your prenatal care.
Yeah. Thanks, Kimberly.
Yep.
This next question was something that was put in the Q&A. And I wanted all the midwives to kind of chip in on this because I know we have lots of good ideas. But are there any books or resources that you recommend reading to prepare for labor and delivery? And I know that Jackie already mentioned Spinning Babies. That's a really good one. And I just want to throw out one of my favorites, which is Mindful Birthing. It's a great book.
I'll throw in one of my favorites. It's probably an oldie by now, but Birthing from Within. And one of the reasons I like that book is because people who are exploring different options for pain management, it gives you a lot of different techniques that you can plug in, and it gives you little ways you can test your own, how well you respond to different techniques. So I like it for that reason.
Laura, did you want to share?
Kimberly, we're showing our age to recommend that. It's a great one. It is great. It's been around a long time. And I think was something I used early in my practice and really shaped a lot of my thinking around birth as well. I also really love the evidence-based podcast. That's a really good one to listen to and get really good, straightforward, factual information put on by a nurse researcher. She also has a book called Babies Are Not Pizzas, which is a kind of synopsis of a lot of her sort of data that she presents, but she goes into way more depth on the podcast.
I like to recommend The Birth Partner. I think it can be read by both the partner or the birthing person, but it's an excellent way for whoever's supporting you to feel like they have tools, especially at home before you come in and while you're there. It gives you a lot of good ways to support someone, especially if this is your first pregnancy, maybe you don't have a doula. It's a good place to start. And traditionally, people used to read What to Expect When Expecting, like back when I was pregnant, and that's like my least favorite book. I usually recommend avoiding that one. And maybe if you want something with that sort of information, Expecting Better, gives some evidence that it makes more sense to people rather than saying, oh, you can never lie on your back and you can never have sushi, because those things aren't really true.
All really great. And I'll also I'm writing all these down too. And you guys will all get like an after program email, and we'll have our wonderful helpers put those in the email, as well as the pregnancy roadmap link too. There's a really great question. Does my OB refer me to a midwife, or do I reach out independently? And you don't have to be referred to a midwife. You can just call and make an appointment. And we'll have our number available on the after, or you can even Google UIHC midwives, and there should be a link to make an appointment. And we have special spots reserved for new OB patients, because we know that people don't know that they're going to be pregnant before they are. So we have them reserved for you. I wonder, can anybody tell me, do you guys know if like the answered Q&A questions, if all of our people are able to see them, like all of our participants? Because there were some really great questions, and I'll read over them if the participants can't read the answers as well.
I was assuming they could, Amber, because there was an option to answer privately or not. And I sent all mine to the main. I didn't select the private link.
Okay, good. A few people said I can read them. Yes, good. Because I was like, oh my gosh, these are such good questions. I wanted to, because one of the things that we usually talk about on this webinar that we didn't get to yet was like, what is the biggest difference between an obstetrician and a physician at the University of Iowa? And we work very collaboratively together. I think our physicians are all amazing. I trust them completely. I do think that one of the biggest differences is like our training and our background, as we were nurses first, and also we have like more time put in our schedules to spend with you. Like we really pride ourselves in educating you and moving forward with the physiologic process. But Andrina's right in her response. We practice the same with the same evidence and things. But midwife literally means with woman. We really try to walk alongside you, have excellent informed consent in our conversations with you to figure out what works best for everybody.
Amber, I would just dovetail on that in our practice, and we're the only ones in our department using this, we actually have a pregnancy checklist where we have an organized plan for your pregnancy care to make sure we cover all the educational topics during your care. And we've developed teaching statements for that to give to you. And of course, if you have a question that isn't on our schedule to talk to you about for later, we'll do it that day. But we really, really value that education piece so much that we have developed a whole plan for you for your pregnancy.
Mm-hmm. And also to piggyback, this is maybe a shameless plug because I am helping with the doulas of Johnson County. We received a grant from Johnson County that if you are pregnant and if you're under 28 weeks pregnant, you may qualify for a free doula if you live in Johnson County. And it's essentially if you meet certain like financial criteria, but if you were to qualify for WIC or Medicaid, you probably would qualify for this free doula program. So if that's something that you're interested in, you could also talk to your provider. Even if you see an OBGYN, they have access to this too. I echo Sarah's sentiment to like ask around and interview several. There is a website called Doulas of Iowa City, and it lists a lot of the doulas, and then also doula match. It's either .com or .net. Is a way that you can put in your due date and then your area, and it'll list out all the doulas that are accepting due dates for that time. So that's a really nice resource too. Listasia, could you answer this next question? Oh, I see you're typing an answer anyway. Do you want to just answer that live for us?
Sure. So the question is, if I deliver downtown and there's a midwife available to deliver my baby, will they have to go back and forth between main campus to downtown, or will they be able to stay throughout the labor and delivery? So when we're covering downtown, that midwife is assigned just to that location. So we're not going back and forth. That is one of our goals in the future is we really, because our main campus site is so busy, we really can't leave it most of the time anyway, even to go over to our offices and things like that. And so we really have to have two different people assigned to those roles at any given time for safety reasons.
Laura Hannah Bergen, can the midwife switch mid-labor due to your shifts?
Yes, that is something that definitely can happen. Of course, we would like to be with you from the beginning to end. That would be the best case scenario, and that does happen depending on the length of your labor. But usually our shifts are anywhere from 12 to 24 hours, and depending on when you come in, it's possible you might have two midwives, and if you're there for a very long induction, you might even have three midwives. So I think and then the nurses also change. So one thing that can provide some continuity for people that are really concerned about the changing midwives is having a doula. And of course, it's not required, and you will get good care. We do try to make our change of shift seamless, like we communicate with each other beforehand just to get an idea of how things are going and what your birth plan is. But I know that's a common thing that people ask about. It's a good question.
Yeah. And I will say we all have like the same training. We practice very similarly. We are all very flexible. Like I saw a question, can I deliver any position I want? The answer is yes. As Megan said, like we meet you where you are.
I think also as someone who's done long extended times of call, like some of us have in the practice, when we come in to do our calls now, like we're very excited and very energized and super excited to be there. And so we're fresh and ready. And sometimes if you're in a very small practice where that person may have been there for a lot of hours, that actually may not work in your favor. So I think, we work really hard and meet every week. Like Amber said, we talk through practice issues and how to handle situations and special requests that people make. So we work really hard to make it seamless, like Laura said.
Megan, if it's okay, I'll pass the next question to you. Does being induced raise the risk for a C-section?
Being induced does raise your risk, and it raises it for everyone, not just because it's your first baby, your fourth baby, whatever the reason might be that you're being induced. It unfortunately increases that risk, increases risk of infection, interventions, increased risk of bleeding. We, of course, do everything we can on our side to help avoid those things from happening. Sometimes we just are not able to avoid that, and we will talk you through that process if that's something that we feel is necessary to happen.
Thanks, Megan. The next question I'm going to shoot to Meredith. Is there medical staff present in the labor room at all times, or is there a good amount of labor when it is just the mother and their support person in the room?
Yeah, that's a good question. Our goal as a midwife, like Andrina had said earlier, is to be in your room as much as we're possibly able to, knowing that we do sometimes have multiple patients at a time, and again, are sometimes covering for our physician and resident teams too. So we will be with you as much as we are physically able to give you that support that you need. There is always a nurse that is working one-on-one with you, and so they too will be able to be there as much as possible to help adjust your monitors or give you that support that you need, get you in those different positions to help your labor process run smoother. But they also too kind of want to give you your time as a family and as a growing family as well. So they're kind of in and out of the room. There's times where we're able to be with you more, like when you are pushing and those times when we're getting closer to the delivery that there's usually, both of us in the room with you. But yeah, there will be times when it's just you and your support person in there laboring as well.
And if you prefer one way or the other, just let us know. Like that's something great to add to your birth plan or your roadmap because we're happy to be flexible in what works best for you. We're pretty good at reading the room. Like some people rather be by themselves and some people need more support. Midwives, one of the questions that we just got in was earlier, each of you shared which campus you work at. Is there a resource that summarizes who delivers where? We don't have a resource for that at this moment, but I will say, is it safe for me to say Midwives majority of us do both locations? But if you want to know, like have a list, we could maybe talk to you, like give you that at your appointment, if that's something you're interested in. Is that okay to say?
Amber, I would say, like, I think it's fair to tell people that there are some differences between Maine and downtown.
Yeah.
I feel like downtown is a little bit more low key. The parking is going to be a little bit closer to the door for you. And the midwives will go over with you, like if you have specific questions, like we are more than happy to address the questions in your delivery planning about, which facility you should deliver at or not. But I think both facilities are great. They both have their purpose. Here, I don't know if anybody else wants to add anything, but I will tell you guys that I was like very surprised whenever I had my first shift down there that I felt like it was a little less hustle and bustle and very kind of quaint and cozy. It definitely has like the more, I came from a smaller town and kind of that small town vibe, which I appreciated, but I'm also so thankful for Maine. Like if there's anything that, makes you a little bit more high risk, if you're more comfortable having that, the NICU present, like, I mean, that's all available at Maine, but I'm thankful that our patients have the option of both facilities now.
Yeah, I think I would just add that there are some differences in which patients can go to which location. So, we go through each person's medical history and their pregnancy risk factors. So it's really like a pretty individual decision based on your own factors. So we would talk to you about that at your visit, like if you wouldn't be eligible to go to downtown for some reason.
Yeah. Sarah, can you talk to us a little bit about, it says, the question is, although pain management is very important on all of our minds, are there therapies that help with non-pain symptoms during labor, like nausea, hot, sweating, etc.?
Sorry, I was having trouble unmuting myself. For nausea, we have like essential oils. We can do peppermint oil, during your labor. Sometimes that helps. As far as, sorry, I'm reading all the things here. Non-pain management. And we have tubs. So either facility you could get in tubs. Warm water a lot of times helps. Moving around during your labor, doing position changes. We have fans everywhere that we can bring in your room. We have birthing balls. We have these things called cubby chairs that I really love. That you can set on if you're not quite comfortable setting on a ball. You can even deliver on those cubby chairs if you chose to. But I think that the main thing is just being supported. And I will tell you that our nurses are spinning babies trained and they are awesome too. at both campuses, and helping you support your labor along with your midwife.
Mm-hmm. Another question we got, are inductions available at both Main and downtown? And yes, the answer is yes. But I think that the more specifically, like, what is the reason for your induction? And I think you should talk that through with your provider so you can see if it's still an okay option to be at, where would be the best place for you to deliver at. We really try to, if it is downtown, we really try to schedule your induction on a day where we have like a handful of us clumped together, because like Laura alluded to, we're really trying to build our practice up so we're able to be at both locations 24/7. And I think we'll get there soon. But just right at this moment, we're trying to clump our call shifts downtown together so that we can cover people consistently. And then if there's not a midwife available downtown, we have you deliver at Main. All right. And then, Sophia, is the golden hour common practice after giving birth, prioritizing skin to skin before getting weighed or tested?
So the golden hour it's really important. I know all of us as midwives in our practice, we are encouraged to let mom and baby bond that first hour. And even at the university, we do respect that golden hour. In case the only time they would not be able to do the golden hour is if mom needs to be stabilized, or baby needs to be stabilized. That those are the times would really separate mom and baby. But we do really prioritize that golden hour. We won't wait baby, we'll leave baby with mom until after that golden hour.
Thanks, Sophia. And I will say, like, delayed cord clamping and immediate skin to skin is something that I think even as an organization, not just midwives, have adapted to. It's something that's really important and research evidence based. And I think it's something that you can advocate for no matter what. The golden hour is so precious because your baby is awake and alert and ready to feed. And we just think it's so important. All right. And then nitrous oxide available at either hospital for pain management, and it's not available at the university campus. I'm working on making it available at the downtown campus, but more to come. Short answer is unfortunately not yet. I think you guys have such great questions. You guys keep popping in with the questions. Good job. Andrina, what is the benefit of trying to get the baby to latch if your milk has not come in yet? That's a really good question.
Okay, so a lot of breastfeeding, the first 1 to 3 days, a lot of that is just getting the sensors in the body to understand that this is kind of where sometimes it doesn't come in, basically, is kind of the short answer. And having your baby latch and having that baby connected to you is kind of going to tell your brain and tell your body that this is what your body's preparing for. And so regardless of whether you can see drops of colostrum coming out or not, having that baby suck and stimulate that nipple essentially will, every couple hours that happens, it's going to continue to tell your baby to start producing the milk, and everything is going to kind of start. So we always say it might be discouraging, but continuing to do that, you will eventually see that start to come in. So just the stimulation in general, is going to be really good for breastfeeding.
Yeah, I totally agree. And also, the colostrum, your baby, this first day of life, the belly is about the size of a cherry, which is 5 milliliters. So the colostrum that you're producing is very dense in proteins and nutrients and calories, and it's perfect for your baby. And oftentimes they don't need more than that until your milk comes in. Jackie, do you provide formula in the hospital if milk has not come in yet?
Yes, it's available. If needed. Our preference, and we've started talking more to our patients about this right now, or in the recent past, would be for you to actually be able to provide your own colostrum if baby needs to be supplemented by doing some colostrum harvesting ahead of time. If you don't have any, there is donor milk available as well.
Thanks, Jackie. You kind of answered one of the upcoming questions about colostrum harvesting. So yeah, we talk about that at one of your prenatal appointments and recommend it. Kelly, do you know of any gestational diabetes resources? Or do any of the midwives know any gestational diabetes resources? I'm not quite sure.
Sorry, I couldn't get unmuted.
That's
Go ahead,
okay.
Laura.
I was just going to say, I really like Lily Nichols' books. She's a registered dietitian. She has a wonderful nutrition and pregnancy book, and she also has a gestational diabetes text as well.
Thank you. Staying active during pregnancy has been encouraged in this talk, which is great. Is there anyone in particular that's more trained in helping with exercise training programs during pregnancy? I was just wondering if anybody in the group wanted to chime in of area resources that they know of. Prenatal yoga is a great one.
Yeah. There are a couple options, I think, in town for prenatal yoga. There are water exercise classes in the community that are not specific for pregnant women, but they are all fine for you to take. You'll probably be the youngest person in the group, which will make all the other members very happy. And you'll get very doted upon, but they are really an awesome place for you to stay active during your whole pregnancy. So I would encourage you to check into that. There are some indoor walking areas to walk during pregnancy. So really, I think it was Listasia one time, and one of these said, you got to have your lungs in your legs when you're having a baby. And that's very true. So I share that with people as well, of that it's important to stay strong.
Yeah, I would add too, I think they're just in our daily lives already, people come into pregnancy usually with some muscle imbalances, and maybe have some chronic, mild to moderate to severe like back pain or hip pain or things like that. And so, getting in to see a pelvic floor physical therapist before, during, after pregnancy, I think is a great idea, because they will do a really in-depth assessment of your strength, and come up with a more detailed plan for exercises that are directed towards the areas you need to focus on.
I would second that. I think there are some really amazing women's health physical therapists around us, and we'd be happy to refer you to one of them. Definitely helpful if you do have a concern for pain or discomfort or an imbalance, but also just general prep for delivery. I think the other thing to keep in mind is that if your body is used to doing some form of exercise, it is fine to continue that. There are elite athletes, Olympians, who continue to exercise and train during pregnancy safely. Just being aware of your body, knowing what feels right and what doesn't feel right, and listening to your body, of course. So.
Thank you.
Can I just chime in on that too?
Yeah, Kelly, please.
I love the idea of somebody staying active in, pregnancy in general, because I think those habits that you start at that time are going to continue on. I think it helps people get through the pregnancy better. I think it helps you get through labor and delivery better and recover on your postpartum period. But the other thing that I really, really love about it is just the positive endorphins that get produced by your body. So it's not just the physical components of the physical activity, but the mental components as well. And I think that, when you go back and you start to look at the mental health of women, I think that it's not stressed enough that physical activity does great things for us, not just shaping a body, but shaping our mind as well. And so I think that that is something that is so extremely important, whether it's meditation or yoga or bar or something like that, just to get that health and wellness balanced in your mind as well.
Yeah. That is a really great point, Kelly. I think that we've got all the questions answered. You guys had such great questions. Please keep writing them down and bring them with to your appointment. We love to talk. We love to educate. We obviously we're all a bunch of talkers. So thank you so much for your time. We appreciate you all, and we look forward to seeing you guys in clinic. Look out for a follow-up email. I have written down all the resources that we talked about, and we will get those passed on to you guys. Have a great night.
Amazing. Thank you to the nurse midwife team for joining us tonight and providing such great information and resources. When exiting from the webinar, you'll be prompted to complete a short survey of our program, and we ask that you please take a few minutes to provide us with your feedback so that we can continue to make improvements to this program and provide our viewers with the best experience possible. This concludes our Meet the Midwives webinar, and I want to say thank you to all of our attendees for joining us.
Bye, everyone.